Okay. Well, good morning, everyone who is online and everyone who is here physically. For those of you who doesn't know me, my name is Rolando. I'm one of the PGY4 neurology resident physicians. So today's going to be my grand rounds, and I'm actually going to be talking about a relatively new topic, which is anti-amyloid monoclonal antibodies and how the amyloid-related imaging abnormalities are linked to these new medications. I want to make sure everyone understands that this is a topic which is essentially, it's a topic from which we are learning every single day a little bit more. I'm not going to be actually recommending using versus not using monoclonals. I'm not going to be going into details about studies done or anything. I'm just gonna basically pose some tools so that we feel a little bit more comfortable whenever we are trying to figure out whether someone has an anti-amyloid monoclonal antibodies ARIA or someone has something else. I'm just gonna go ahead and mention that I do not have any conflict of interest. So today's CME code, it's on the screen. So every one of you can just get the code and you can claim actually a little bit later your CME code. I'm not gonna spend that much time with this code on the screen because the code will be actually on the screen several times during my presentation. So feel free to go back. Even in the last slide, you'll be able to see the code as well. The subjects we are actually going to be going over will be a little bit of the background about why we are talking about this today. I'm gonna just introduce you a little bit about what amyloid-related imaging abnormalities is, some of the pathophysiology related to this condition, and also some of the risk factors, imaging, clinical presentation, a little bit of the differential diagnosis, some pitfalls we should avoid all the time, as well as disease course and treatment, so that we can have a better idea. I have to start saying that in 1906, this gentleman on the screen, named Alois Alzheimer, who was a German psychiatrist, he was the first one actually who reported a case of a woman. This lady was in her 50s. She was seen with paranoia and memory loss, which was followed later by aphasia. And then she eventually lost her ability to perform any kind of motor tasks. When they did the autopsy after she passed, the gross inspection was relevant for essentially an atrophied brain with some vascular changes. But when they took a look actually at the microscopic slides, it's when they, for the first time, found those Alzheimer's disease hallmarks, what we know today as amyloid plaques and neurofibrillary tangles. Then, with the years in 1984, it was, I think, around that time, the first time the Alzheimer's disease was conceptualized as a clinical pathological entity. Later, around 2011, those criteria were revised. Of course, with the advancing technology at that time, the possibility to do in vivo detection of amyloid with PET scan, cerebrospinal fluid, as well as different tools to measure neurodegeneration, then the individuals could be better characterized as normal, mild cognitive impairment, or dementia per se. Just to give you an example, if someone had amyloid and neurodegeneration biomarkers were present in conjunction with the clinical syndrome of dementia, the diagnosis of dementia due to Alzheimer's disease could be made with a high likelihood. In the 1990s, actually, the Alzheimer's disease research came to be dominated by the amyloid hypothesis. This hypothesis essentially stated that the accumulation of amyloid beta was the main issue triggering the neurodegenerative process. This neurodegenerative process led to loss of memory and overall a reduced cognitive ability. Of course, many scientists saw right here a great opportunity to treat Alzheimer's, right? Either by preventing or clearing the building up of those amyloid plaques. I have to say that around 1999, some researchers at Elan Pharmaceuticals in San Francisco, California, they actually became the first one to clear beta amyloid plaques from the brains of mice by raising antibodies against amyloid beta. Then later, Scant and colleagues noted that the reduction in plaques, as well as being associated with anti-amyloid beta antibodies in the blood, was in fact correlated with an increase in microglial cells, which, by the way, were capable of binding to the amyloid in the brain specifically. So this essentially suggested that antibodies might facilitate the clearance of the plaques by binding to the microglial cells and therefore triggering the uptake of amyloid beta. Again, in 2003, the Elan Pharmaceuticals team, led at that time by Frederick Barr, demonstrated that directly administering antibodies against amyloid beta, rather than, in fact, stimulating the body to generate antibodies on its own, had a similar effect on plaque clearance. So it was essentially the same if you just gave them antibodies than if you just gave them vaccines. And of course, those studies started, we're going to mention a few of them, like, for instance, that study that was done with bapineuzumab in 2009. It was a trial that essentially enrolled 2,034 patients, all of them with mild to moderate disease. And then they were randomly assigned to either IV monoclonal antibody or placebo. In fact, I have to say the results of these studies didn't show any significant difference, but something was noticed at that time, and it was that reversible edema was detected in the brain MRI of approximately 12 people out of 124 patients. And that was representing around 9.7%. Another study that took place as well was a phase 3 trial with the same medication that happened in 2014. Again, this one was a little bit more representative. 2,452 people were enrolled. Again, there were no significant between group differences, and the primary outcome was not demonstrated, in fact. But again, the major safety finding was amyloid-related imaging abnormalities with edema. And of course, those were majority of those patients receiving bapineuzumab. Another one was a trial conducted in 2018, or at least published in 2018, with solanezumab, which again, it was a double-blind, placebo-controlled phase 3 trial involving patients with mild dementia due to Alzheimer's disease. They actually enrolled 2,129 patients All of them were enrolled. 1,057 were assigned to receive the medication, and 1,072 were assigned to receive placebo. Again, ARIA E was found in 1 and 2 patients respectively in the group of the medication and the placebo. Just to mention that 3 of them were asymptomatic. And we're going to be talking a little bit more about how ARIA presents actually, and how do we monitor for ARIA even when patients are not having any symptoms. Another of the studies was the one on aducanumab, phase 3 trial. This one with the design of emerge and engage, 1,638 and 1,647 participants. Only 55.2 completed the study. And, the interventions were essentially a randomization of 1 to 1 to 1, in which a few people received the medication at a very low dose. Some other people received the medication at a high dose, and some other people received didn't receive the medication, but they just received the placebo. Again, the most common side effect for this was amyloid-related imaging abnormalities, edema. Just recently, and the one that probably everybody knows about is lecanemab, who was essentially a design of 18-month multi-center double-blind phase 3 trial, involving actually persons between 50 and 90 years old, diagnosed with early Alzheimer's disease. A total of 1,795 participants were enrolled. Of them, 898 were assigned to receive lecanemab and 897 to receive placebo. In fact, the lecanemab actually did show some reduced markers of amyloid in early Alzheimer's disease. But again, this is not going to be the main topic we're going to be talking about today. There were no deaths considered by the investigators to be related to the medication itself, or actually with the occurrence of ARIA. And ARIA E and ARIA H were detected, specifically the first one in about 12.6%, and the second one in 17.3%. We've heard a little bit about the background at this point, so I'd like to start introducing the topic a little bit more in depth. And I'd like to pose this challenge question, which is essentially a 74-year-old female patient who is being treated with an anti-amyloid antibody therapy, and now comes referred with the main complaint of dizziness. So this patient is essentially symptomatic and is coming complaining of dizziness. On physical exam, the only thing you notice basically is her blood pressure to be a little bit elevated. She is referred for an urgent MRI. And when you take a look at T2 flare, it shows a 5.5 centimeter parenchymal hyperintensity. And you also see some susceptibility weighted scan showing some microhemorrhage in the same spot of the previously mentioned lesion. There is also restricted diffusion, and I'm going to go ahead and show you the image so that you can have a better idea. You have the 3 sequences, flare, GRE, and DWI, and I just want you to try to remember these images. As we're going to go ahead and ask you all, if you were so kind, and scan that QR code and try to enter the answer you think is the right one for this question. I'll give you 20, 30 seconds. And those people online, feel free to also scan the QRS code and go ahead and answer your question if you would. All right, so far we have 13 answers submitted. 84% think is moderate area E and mild area H. 7% think is severe area E, moderate area H. And some other people think is an area on top of an acute ischemic stroke. All right, let's see what the answer is. Okay, so in fact, this is an acute ischemic stroke. It's actually early subacute infarct. And here is one of the things that I thought this would be a great topic to talk about today, because we look at these images and so many times we don't really understand what we're looking at, and we don't know what to find in each one of the sequences that we are looking at. So again, you have a T2 flare in which you're seeing some hyperintensity, and you have a GRE in which you're seeing some hyperintensity corresponding to bleeding. But you also have DWI, and DWI will essentially tell us about cytotoxic edema. So you should not expect to have any cytotoxic edema in a patient with ARIA, but instead you should be waiting to have some vasogenic edema, which is the main finding. Now, I'm not saying that you cannot have some mild cytotoxic edema related to it, but it should not be predominantly cytotoxic, as we can see right here. It's pretty much about the same size of the T2 flame. So that's it. That's the first topic. And we're going to talk a little bit more about what are the images and what are the modalities and sequences we should be using every time we're going to try to diagnose someone with ARIA or ruling out some other conditions. Ali?
So we don't have any ADC image?
No, we don't have ADC. We actually don't need ADC at the time we are going to diagnose ARIA again, because we should not be expecting to have, we do need DWI, and we'll see some images about ADC later.
The second image is DRE.
The second image is DRE, yeah. And we're going to talk about what the recommendations are when it comes to GRE versus SWI.
You said there was no enhancement.
There should not be enhancements. That's another topic. This is not there is no contrast. I'm gonna show you an image later as well, in which we're gonna go over some differentials. But yeah, so essentially amyloid-related imaging abnormalities are related to the increased permeability of the blood vessels due to amyloid deposits. I have to say that both fluid and blood products can leak either spontaneously in the setting of cerebral amyloid angiopathy, and this is what we call spontaneous ARIA, or as a result of the mobilization of the amyloid plaques by the monoclonal antibodies. The thoughts actually about these MRI changes being due to vasogenic edema and cerebral microhemorrhages were, as we know, first reported in those trials with the monoclonal antibodies, specifically in 2009, with the first one, bapineuzumab, when they did this treatment with the monoclonals targeting the amyloid plaques. So essentially, we know two types of ARIA. One is going to be ARIA E, which is going to be related to cortical vasogenic edema and sulcal effusion. And the other one is known as ARIA H, which is going to be essentially hemosiderin deposition due to superficial siderosis or microhemorrhage. A little bit of the pathophysiology of this condition. And again, I'm not going to go into big details right here or different hypotheses and controversial topics about what is right and what is not right. I'm going to essentially talk about what the theory is for this specific condition. So we think it's a toxic amyloid beta undergoing aggregation in the brain. And once the monoclonal antibody actually removes the amyloid plaque, which was previously aggregated, it will essentially create this clearance, which is going to lead to increased permeability of those blood vessels. So an important thing that we should know about this is like that vascular integrity loss should be transient. And that vascular integrity loss, it's actually responsible for the increased signal that we see in these MRI sequences. Well, I'm talking about ARIA E and ARIA H. In fact, the evidence so far is suggesting that the repeated immunization and continued beta amyloid clearance will actually decrease the risk of ARIA. And I'm going to show a couple of pictures later about that. Again, it's a very controversial topic. We know that we can talk a lot about this, but I'm just trying to offer you a summary of whatever is out there. All right, so this is the image I was talking about. As you can see right here, this is a follow-up of a patient that was treated with bepinosumab. It's actually a 69-year-old female who received the medication initially at a dose of 1 milligram per kilo IV. And you can see how the pre-dose MRI doesn't show any hyperintensity. However, when she received the first MRI, the routine MRI at 7 weeks, you can start seeing some hyperintensities, right, to the posterior occipital bone. And you can see how that hyperintensity at the 7 weeks will decrease by the week 13 and will progressively decrease by the week 19. And you essentially don't see anything at the week 58. Of course, after this patient was detected to have ARIA, she was redosed. And instead of receiving 1 milligram per kilo, she was then receiving 0.5. But again, something to just have an idea about this being a transient process and how the repeated immunization seems to even improve this condition lately. Some of the risk factors we should know about the developing of the disease. I'm gonna actually mention the 3 most important risk factors, which are gonna be cerebral amyloid angiopathy, apolipoprotein E epsilon 4, and the amyloid lowering therapies, of course. We all know that the cerebral amyloid angiopathy and the presence of relapsing inflammatory cerebral amyloid angiopathy, which is a different condition, will be often associated with the superficial siderosis. And this will be essentially a very important risk factors for these patients, something that we for sure look into every time we get one of these first MRIs. The apolipoprotein E epsilon 4 is actually one of those present for pretty much every patient. And of course, those receiving the anti-amyloid therapy are just at a higher risk of developing the condition. There are some other risk factors that sometimes people don't talk about, and we actually went over one of them right here. And just go back and remember the image we took a look at 7 weeks. This lady developed the first hyperintensities in the T2 flare sequence. So actually, the early treatment has been cited as one of the main risk factors. People actually within the first 7 weeks, it's a time in which they most likely will develop these abnormalities. But there is another risk factor that we sometimes forget, and I think it's important to mention, and that will be anticoagulation. So those people receiving concomitant anticoagulation are, of course, at a higher risk of developing amyloid-related imaging abnormalities. And here, you have the CME code again. So I'm following Lilia recommendations. So go ahead and get your code so that you can claim your CME. All right. So we'll do another challenge question. This is a 66-year-old female patient that has been actually diagnosed with mild dementia. This is due to Alzheimer's disease, and she began an anti-amyloid therapy. She has received a total of 4 infusions by now, and she's coming today because she will receive the first MRI. So this is just to monitor for any ARIA, a symptomatic ARIA, because she's going to be completely asymptomatic at the time she's going to get that. So, in fact, my question here would be, what set of MRI protocols do you think she should receive? And I'm giving you some choices. It's fine if you're not sure, you can actually say you're not sure. Otherwise, you can go over those different sequences and choose whichever you think is going to be the right one. Okay. Nobody's unsure yet, so everybody's pretty sure. Well, actually, 40% answer correctly, and 40% on well, not 40, but 60%. Well, now it's changing. Anyways, I think we have a representation now. So, yeah, it's actually, in fact, the last choice. You should have a T2 flare DWI. I'm sorry, SWI, and you should also have a DWI with contrast. Couple of things to be aware of right here. So the first one, area E and area H, both will essentially exhibit vasogenic edema. So, like I said before, if we are talking about vasogenic edema, and we all know that there is something I think we should know, right? So once you look at these images, you always know that there is no way you'll see only cytotoxic edema or vasogenic edema, but definitely there will be edema, one type of edema, predominantly over the other one. And so essentially, like I said, area E and area H will exhibit this kind of vasogenic edema. Area E and area H will not exhibit DWI hyperintensity. Again, there is no cytotoxic edema, so you should not be expecting for DWI hyperintensity. Area E and area H will not exhibit contrast enhancement. It is not essentially, there is no contrast enhancement that you should be expecting. And that it's something that you should do because so many times. And again, is this absolute? No. But once you see contrast enhancement, you should probably think of something else. And I'm not gonna say anything else because later we're gonna see another question which that will be one of the possible answers. All right, so let's gonna talk a little bit about images itself. So we already know that cerebral amyloid angiopathy can cause spontaneous ARIA in patients with Alzheimer's. We know that the surveillance MRIs can be used in patients with Alzheimer's disease, undergoing treatment with monoclonal antibodies to remove the amyloid plaque. And we already heard about the two different types of ARIA, ARIA E and ARIA H. We actually do some baseline images for these patients. And we sometimes ask, well, why do we need a baseline image if we haven't started these patients on any medication? Well, we need a baseline image because we need to exclude whomever is not a good candidate to receive these monoclonal antibodies. And we're gonna go over some of the details, but essentially it will help to exclude those that are at baseline suffering from cerebral amyloid angiopathy and will be at higher risk of developing further complications. Remember that the typical criteria for removal of these patients in these studies will be at least individuals with 4 lobar microhemorrhages. Notice that I'm saying lobar microhemorrhages. I'm not talking about subcortical, pontine, brainstem. I'm talking about lobar microhemorrhage or those with superficial siderosis. That will be another of the criteria you're going to be using. Of course, those that already exhibit previous hemorrhages also will be classified as not a good candidate to be. And again, remember that these agents, they essentially produce a transient state of increased vascular permeability. But you should actually wait for some reconstitution of the blood vessel integrity with the time. And again, you're going to provide a baseline image to compare with, future images. A lot of times we wonder what kind of image should be the right one. There will be people talking about what kind of MRI. Should we do a 1.5 Tesla? Should we do a 3 Tesla? Should we do a 7 Tesla? It depends, actually. Of course, the more Tesla the MRI, the more quality for that image. But again, we do have some basic standards. And the basic standards for this patient is, first one, 1.5 Tesla. Second one, what they actually want with these images is reproducible images quality, meaning that every time the patient go and get one of these images, the suggestion is to get these images with the same vendor. Should not go and get one image from, let's say, University of Ohio, and then coming over Louisville, Kentucky, and get another image. You should actually, the recommendation is to get the same image or the images with the same vendor. The same radiologist should be ideally the one reading these images. And there should be a continuity about that. The images recommended, essentially, like I said, are DWI, GRE, or SWI, T2 weighted, and specifically FLAIR. Couple of things that we should know about these is, again, people will ask, well, what about the difference between GRE and SWI? Yeah, it's there definitively, but remember that these studies were actually conducted in several countries. And the main criteria to talk about ARIA and to classify ARIA was essentially they used the image sequence they used was GRE, was not SWI. Now, if you are in the United States and you do have, of course, SWI, then of course, go ahead and get SWI. But that doesn't mean that if by any chance you're working at an institution that doesn't have this image sequence, you are not going to be able to follow up with these patients because you don't have that sequence. And when it comes to the T2 weighted images, of course, you prefer flare over any other image because you want to get rid of the cerebrospinal fluid confounding factor right there. And I will actually show you probably some of the hyperintensities that are not related to ARIA itself. Let's see this question now that we're getting a little bit more into the topic. 74-year-old male patient, recently diagnosed with mild cognitive impairment due to Alzheimer's dementia. Referred for a brain MRI to determine his eligibility for treatment with an anti-amyloid antibody. His brain MRI reveals 2 microhemorrhages, each one of them 1 millimeter in diameter. A third hemorrhage was about 6 millimeter, and he also has some moderate atrophy in the hippocampus as well as gray matter. And he does have some white matter hyperintensities, mainly to the frontal lobe. Okay. Do you think he should be excluded or not? Or are you unsure? It keeps people awake, I guess. I'm sorry? Is MRI findings? Oh, back to the question.
What's an area? Let's look at images. Never trust radiology. Never trust radiology. Never trust radiology.
All right. Okay, so we have a huge percent of the audience inclined to the fact like these MRI findings exclude him from being eligible for treatment. So I'm not gonna give an answer right now. I'm gonna go over the next few slides and we're gonna come back to these a little bit later. So the incidence of ARIA, actually those patients received monoclonal antibodies, or ARIA-E is something in between 0.9 to 40.6%. ARIA-H, something in between 0.5 to 28.4%. As symptomatic area, it's something in between 74 to 89%. And this is really important because this tells us that pretty much those patients out there can be suffering from ARIA, and we don't know anything about that because they are not actually experiencing any symptoms. The symptomatic severe ARIA, it's only 4% of that. So don't wait for the symptoms to come up. That's why we need actually to monitor these patients. A little bit about ARIA-E specifically. We already know that it can exhibit 2 different patterns. The first one is what we know as basogenic edema, and this is flare hyperintensity, right? So it's due to parenchymal edema, and this parenchymal edema is essentially protein, right, leaking into the parenchyma itself and the interstitial fluid compartment. But you can also have sulcal effusion, in which you're going to have also some flare intensity or hyperintensity with essentially sulcal abnormalities. Again, this is going to be also to fluid leakage, essentially proteins, but in this case, will be into the leptomeninges and the subarachnoid space. Here is an image so that everybody understands what I'm actually talking about. And so you can see right here how the sulcus, it's more compromised. And you can see right here how some sulci are compromised, but also the parenchyma is affected. You can further classify these as mild, moderate, and severe. And it's really easy, right? If it is less than 5 centimeter, it should be mild for only one location. If it is something in between 5 to 10, it should be moderate, unless we are talking about more than one location, in which you will also say that can be moderate. And if you're talking about more than 2 locations and the 2 of those are more than 10 centimeters, then this is for sure severe, right? So it will also allow you to say, you know what, this patient should probably stop the medication at this point. We can actually continue the medication and increase the monitoring of this patient, or we should just go back and discuss with the patient what they want to do, but they definitely need to know the risks they are taking. ARIA age, we do have 2 types right there, like I said before, superficial siderosis and microhemorrhages. For the superficial siderosis, we're gonna see T2 GRE, and they're usually curvilinear hyperintensities. This is due to the blood products, which are into the subarachnoid space. And they are essentially attributed to the deposition of iron in the setting of the, or in the form of the hemosiderin. I have to say that the baseline prevalence of this condition has been estimated at approximately 0.21% among those aged 50 to 69 years old, and 1.43% in those a little bit older than 69 years old. But you also have the microhemorrhages, which are essentially scattered punctate foci of signal void on T2 GRE. These are in the parenchyma, right? And so typically you do know that they are there because they are less than 10 millimeters in diameter. And just important to know, they increase, the prevalence of these increase with age. Just to give you an example, around 60 to 69%, or probably 17% or around that number, will exhibit already microhemorrhages. But that number goes up to 36% in those between 80 and 97 years old. Here is an image so that you can get an idea. And you'll see right here. And on the other one, you can see the microhemorrhage. The first one are salt size. Yeah, these are salt size. This one is a microhemorrhage. Yeah, the image is not that good. The quality of the image is not that good as I would like to. But that one is essentially, this one is essentially in the parenchyma, and these one are in the salt side.
The same principle applies to ARIA-H.
I'm sorry?
The same principle applies to ARIA-H, because in the slide was ARIA-E, with like circular fusion and 52 hyperintensity.
I don't understand the question.
That's a
Two slide. Yeah, this is C and D. This is completely. Yeah.
Okay. Is there any circle or parenchymal location that
It's always low. That's lower hemorrhages, microhemorrhages, it's gonna be always lower. If you see microhemorrhages subcortically, or if you see microhemorrhages at any other level, those don't count initially. And in the first MRI, you'll have to get at least, you are allowed to have at least 4 different microhemorrhages for you to be able to get, because what you're gonna count essentially are new microhemorrhages. You're not gonna count the total. If you get the first MRI and you already have 4 microhemorrhages, you're good. Now the next one, if you have 8, those are not gonna be 8 total, are gonna be 4 new microhemorrhages on top of the other 4, which is gonna be the.
My understanding is that the microhemorrhage is almost always intraparenchymal. There's no.
Oh, no, I get your question. Yeah. One thing is microhemorrhage and the other thing is a superficial siderosis. Yeah. Sorry, I didn't. Again, you can classify them as mild, moderate, and severe. For the superficial siderosis, what you will see is for mild, one focal area, moderate, two focal areas, and severe, more than two focal areas. For the new microhemorrhage, will be less equal than four, something in between 5 and 9, and more equal than 10. And again, these are only new microhemorrhages. You do not really count the previous microhemorrhage that you get when the patient is actually scanned at the very beginning. This is an example, and what I want to make sure we understand right here is that this is an example of how you monitor one of these patients, right? But this is specifically for a patient receiving lecanemab. The problem here with these medications is you really need to follow the recommendations of the pharmaceutical company about when is the right time to do the monitoring for ARIA. Each one of these medications will definitely have a different way to be monitored, and they will also have a different criteria to be stopped, right? And that partially answers the question we did earlier. You do have an idea when a patient should or should not have the medication, depending on how the first MRI looks like, and depending on how the second, third, and fourth MRI looks like. But you definitively need to know that each one of these medications is completely different, and the recommendations are going to be specific for each one of them. Another challenge question, 69, female, mild Alzheimer dementia, receiving monthly infusions. This is the third safety MRI. And we know, actually, at this point, 3 new asymptomatic T2 flare left occipital white matter hyperintensities. Each one approximately 6 centimeters in length. And there is also 3 areas of superficial siderosis. How would you actually characterize these findings? And this goes back to the classification, either mild, moderate, or severe.
We're gonna fit 3 6-centimeter lesions in one occipital lobe. Go back.
You do the 3D. You do not actually do only the axial code, the actual code. You will do the 3D because when they see more than one, actually, what they recommend is to do the 3D, or when they see those big images, they do recommend to see to look at the images in the 3D dimension so that they can have a better idea about the size of the lesion.
Then 6 centimeters.
Yeah,
3 of them.
3 of them.
And they're all in the same optical lobe.
Yeah, I didn't have I didn't have the image.
Cross.
I didn't have the image though. We need the images. We cannot trust. One of the things they were actually recommending when they're reading these MRIs is specifically not to underread these MRIs. You should not be only looking at what the image itself, the hyperintensity, but also the area and the sulci surrounding that hyperintensity. So not only the parenchyma, but also the sulci surrounding that should be counted and should be actually measured. Because it makes sense. So the last thing you want to do is giving them a medication that it's going to put them at a higher risk if they are already exhibiting some kind of inflammatory condition in their brain. Yeah. So this will be, I would say, multiple,
More than one location.
yeah, more than one location, less than 10 centimeters,
Area is more than-
and we have superficial cirrhosis. And the answer here will be moderate area E and severe area H. That will be the answer for this question. Important to know, like I said, we do have, for moderate, we always have like more than one location. Doesn't really say 3, 4, 5. It's more than one location. But we don't have any of these images measuring more than 10 centimeters. So we're talking about multifocal, right? So that will be the key of the question right here. All right. So again, a little bit about the clinical presentation, just for us to know, most cases of ARIA, like we said before, are asymptomatic. Moreover, these cases occur early in the treatment course and decrease with the increased duration of the exposure to the medication. There are some other kind of symptoms that you can find, but they are not actually present all the time. You can definitively see people complaining these symptoms when they are suffering from area E, mostly, and those are headache, confusion, dizziness, nausea, some neuropsychiatry symptoms, like a little bit unspecific, but these unfortunately are most of the time very vague. And some of the less frequent symptoms, but sometimes are complained, are fatigue, visual impairment, blurred vision, and gait disturbance. Seizures are also one of the symptoms coming with these medications, and they definitively need treatment with anti-seizure medications once they are present. The differential diagnosis, a couple of things to know about this, because I think it's important. What we see right now is that the recommendations are very specific about taking into account scanner or sequences variability for each one of these patients. Again, that's when it comes down to the importance of getting these images probably with the same vendor other than going to a different place, and the artifacts. So making sure like we're getting a T2 flare with a good quality so that we don't have any kind of artifacts coming from the cerebrospinal fluid. It has been seen and mentioned some of the cases receiving a high dose of oxygen. And we do know that this high dose of oxygen actually creates a pattern in which they do show some like a hyperintensity in T2 flare. In general, all kind of imaging artifacts given by movement or any other artifact related to contrast, those patients in which we do this T2 flare sequence and we don't get the right water suppression will be also another thing that we need to bear in mind all the time, just to make sure like we're not either overreading or underreading these MRIs. Stroke, we saw that in the very beginning. We need to make sure like we understand exactly what sequences we need to use and how we rule out strokes for these patients. Subarachnoid hemorrhage, posterior reversible encephalopathy syndrome, malignancy, and the flow void artifact that we can also see from some of the images. I did bring essentially very briefly some images kind of illustrating what we were talking about. Again, right here, we're going to see the parenchymal flare, hyperintensity of area E edema, and we know that that can mimic essentially an ischemic stroke. But again, the diffusion-weighted images will be needed in this case to differentiate the two of them. And another thing that I guess like, not because I didn't mention before, we are going to forget about it. We're talking about a patient with symptoms, right? So a stroke will present characteristically with a syndrome that we should be able to differentiate, not with only a headache or a blurred vision or something along those lines. So the clinical picture also will help us to kind of differentiate among these patients. Like, I have a question. Yeah, go ahead, Dr. Friedland.
Yes, can you hear me?
Perfectly fine, sir.
Thank you, Rolando, for your comprehensive report. There's at least one elephant in the room. What do you think of the efficacy of the monoclonal antibodies? If all of the consideration of your talk is about the complications and the monitoring of the therapy, but what do you think about its efficacy? Are you prescribing it?
Yeah, great question, Dr. Freeland. Thank you so much. So I definitively, like I mentioned in the beginning, there are a few of these topics that I didn't really go into the nitty-gritty details. There is a lot of controversy out there about how effective one medication over the other one can be. At this point, it is my understanding that these kind of treatment are being offered to the patients. And beforehand, all these complications are kind of explained to each one of them so that they can actually go ahead and make their choices depending on how they feel this medication can either benefit or harm them. I do recognize that at this point, probably we don't have the strongest possible evidence to say that one medication is superior to the other one, or this is essentially the treatment we want to do for each one of these patients. It's unfortunately, I guess, like all we have after the anti-cholinesterase inhibitors in the past, such as rivastigmine and galantamine and donepezil and those medications. Like I said, I do recognize at this point they might not be as effective as we want to, and we are kind of learning. I feel like we are kind of learning about the side effects at this point. So I feel like for me to say one way or the other right now will be probably a little bit precipitated. And we are just, I guess, like a couple of years into the trials and the treatments. So I will be kind of cautious, but I do recognize that there are some concerning issues, and that's why I brought this topic to the Grand Rounds today. I don't know if I actually answered your question. Dr. Brown is asking.
So in ALS,
See, well,
so in ALS, there was preliminary approval from the FDA for a drug that had a signal that it was going to help, and so it was approved to avoid an uproar from the patient community, so that the drug is available even before the clinical effects are known. So is there a larger study being done right now to show that the effect of this drug is not just a radiologic, it's not an MRI modifying therapy, it's a disease modifying therapy. Right now, do we know if this is a disease modifying therapy or is it an MRI modifying therapy?
Yeah, I'm not completely sure about that. I guess like we like I said in one of my slides, the thoughts were that at least from the very beginning that this was essentially a direct result from the treatment itself, from the use of the monoclonal antibody. So far.
Is there a larger study that is ongoing, a longer, larger study?
Yeah, I'm not sure about that. I'm not sure if it is another ongoing study, but I think as we are kind of trying this medication and continue to giving these medications to the patients, we are kind of continue to collect data on each one of them just to kind of see.
But we have positive trials, but in terms of CDR score, like clinical dementia rating scale,
Yeah,
imaging evidence of lowering of the
We-
plaque
yeah,
burden,
we definitely have.
emerge, gain, and
Yeah.
plenty of other.
Again, I'm not gonna be able to answer most of these questions today because I didn't go into, I think we can do more than one round about each one of these medications and how they were kind of studied. I focused my presentation pretty much on just this side effect, and it's more even about how to be aware of it and being able to identify these imaging abnormalities.
I have submitted systematic review and meta-analysis to the AAM
Mhm.
for the efficacy and safety of these monoclonal.
Okay.
In the next, like my lecture, I can take up that.
Okay. All right. So, yeah, Dr. Friedlang is actually texting. I recommend everyone to read Doctorate by Charles Tiller, which discusses the conflict of interest among Alzheimer's researchers. Thank you, Dr. Friedlang.
Thank you. Thank you.
All right, and so again, another of the images that you should also consider in the differential diagnosis would be posterior reversible encephalopathy syndrome. If you look at the two of them, you'll see how each one, it's kind of similar to the other one. It's a vasogenic edema, but of course, remember that PRES presents in those patients with preeclampsia, receiving some kind of preeclampsia or autoimmune disorders, receiving medications, those with sepsis, renal failure, and of course the clinical picture as well, right? So encephalopathy, seizures, visual disturbances that will be also present in those patients with PRES. Course prognosis, complications, like I said before, the knowledge right now we have, and this might change in a little bit, typically ARIA resolved over several weeks. They were saying that apparently at 12 weeks, 62% of ARIA had resolved, and at 21 weeks, 81% had resolved. Of course, this is not for everyone. There will be certain amount of patients out there that ARIA won't resolve. And at least one of these studies reported the death of one of the patients that underwent ARIA, to my knowledge. Post-ARIA cognitive assessment suggests that ARIA did not lead to any worse cognitive or functional outcomes. Some manifestation of a severe ARIA may not complete, and that's something that we were just mentioning before. And there are, these studies are also reporting the volumetric MRI demonstrated that donanemab and lecanemab produce, both of them, loss of whole brain volume with reduce of the hippocampus. However, they did mention that the reduce of the hippocampus was not directly proportional to the whole brain volume reduced. And so the clinical significance of that, I don't know if it is already known, but to the point that I was actually kind of looking into everything, I don't think they know exactly. I just gave you a little bit of examples about these studies. Again, not gonna stop and talk about them because each one of those only need one grand round to talk about them, but just something to bear in mind. The treatment management for these conditions can be summarized in the same way. So you can actually perform an MRI, and if the MRI shows either ARIA-E or ARIA-H, but those patients are asymptomatic, then you should probably continue treatment with an MRI monthly, and then depending on what that MRI monthly will show, you can definitely discuss with the patient whether they want to stay or not in the treatment. The recommendations again at this point, for those with moderate to severe ARIA, will be to immediately stop the treatment and repeat an MRI monthly. Now, some of those are going to be considered for restarting the treatment again. Some of those definitely won't, but something just to bear in mind. And then a few recommendations on how and when to stop monoclonal antibodies for these patients. First one, severe symptoms of ARIA, more than 2 episodes of ARIA during the same treatment, More than 10 microhemorrhages since the treatment initiation. Again, we don't necessarily count the first microhemorrhages seen before those patients received the treatment. Any microhemorrhage, those patients should be stopped immediately. More than one area of superficial siderosis, and those patients who are currently receiving anticoagulant therapy. Serious and severe ARIA should be admitted. There is no discussion about that. These patients should be admitted. They should not be treated outpatient. Severe edema and signs of intracranial pressure may be treated with glucocorticoids, specifically 5 days followed by a gradual oral glucocorticoid taper. What they are recommending right now is methylprednisolone 1 gram IV for the 5 days. And like I mentioned before, seizures should be treated with anti-epileptic drugs. Here are some of the references you can use just to go back and kind of learn a little bit about it. I'm pretty sure that as the time goes, we will either confirm or deny most of the discussion we have been sustaining here today. But I guess that will be something that we'll need to wait for. Here is a code, one more time, CME code, 3 times Lilia. Thank you so much, everyone. I don't know if there will be any questions from the audience. I'll try to answer them as much as I can. Okay, well, thank you, everyone. Have a nice day. Can you have TNK? Yeah, you should not. No, you should not, definitely. There is no guideline yet out there, but there is a case at least reported of a patient who passed, came in diagnosed with a stroke on monoclonal antibodies for dementia. They gave TNK, he unfortunately passed.
That's what current American relative or after the conflict.
Yeah, I don't think there is a current guideline about it. Yeah. All right, thank you, everyone.
So much.